So today is, everyone says, oh, today is Presbyon Day. No, today's not Presbyon Day. Today is about how to treat presbyopia in the absence of cataract. And I want to be clear about that, because if we were going to be talking about cataract surgery or refractive cataract surgery, this would be a different set of lectures. And I want to make that distinction. I want you to keep that in your mind the whole time. I'm talking about a presbyopic patient who has no cataract, including a 65-year-old who has 2016 best corrected, normal contrast, and an OSI of 0.6 or 0.8. That is no cataract, okay? So I want to distinguish these two fields, because once you start to meld those, then the arguments get very confusing. So that's the most important thing to keep in mind. The second thing I'm going to do is I'm going to try and approach the whole subject, not just part of it, so that we're not just talking about presbyon, but we're also talking about lens surgery and why and in what context. So, about presbyon, one needs to understand that, like multifocal surgery, it is a system. Now, last night we were having drinks and we were talking about patient selection for multifocal IOLs, and even in cataract patients. And the personality, and someone has to be like this and not too exacting, and has to be able to drive at night because they live in the country and there's no street lights, and you know they got to be a little bit laissez-faire, and perfection is not necessarily important to them. All, you know, well, okay, well, and then post-op managing the patient who is not neuroadapting, and then what do you do then? And all, okay, presbyon is also a system. Right? In other words, if you're a vitreoretinal surgeon and you just say, I'm going to put a multifocal in, boop, and just put it in, and you just keep on doing that, you're going to get into a lot of hot water, right? Because he's not using the system. We have that in the UK. We have vitreoretinal surgeons who, on a private practice day, will just lob a multifocal in without refractive surgery training. So presbyon is a whole thing. And it starts, like all of refractive surgery, with marketing and communication. And marketing is like a dirty word in the medical field, but if you understand that word scientifically, you realize that people who have degrees in marketing and masters and PhDs in marketing, they're scientists, they're statisticians, and they're artists, and they have the art of using communication skills to reach target audiences in order for those people who want a product to be able to access it. There's nothing dirty about it. It's the methodology for the person who wants something to get it. On the other hand, it's good for the business who's delivering that product to be able to find the people that want it. So it's not a dirty word, but you need to understand that it is critical to refractive surgery, and especially in presbyopia, because the knowledge in the general public about presbyopia treatment is zero. No one knows that presbyopia can be treated. And of the people who know, most of them are told the only way that laser can't do it, and the only way to do it is to have a lens replacement. So that's the state in 2023. I'm going to make a mention about marketing and make some suggestions also later in the lecture. So then there's the pre-op assessment. Okay, so just like in multifocal IOL surgery, you have to assess the patient. The difference is that apart from having to check whether they don't have dry eye, what you have to do is go through a very simple standard operating procedure in refraction and what we call the +150 acceptance test. So refraction you have to do anyway for all refractive surgeries, but you have to do it like this, because if you don't do it like this, then the software nomogram won't work. You'll have to develop your own nomogram. And the scatter of your results will be less good, and you'll do more enhancements, and it'll be just harder for you. So I know you've all been refracting your whole lives, but if you want to do Presbyond, unless you want to do a lot of extra research yourself, the recipe, you know, you can Google the recipe for Presbyond. The recipe says number 1, number 2, just do what's on the recipe. And if you do what's on the recipe, then you'll be able to put the numbers into the software, and there's no extra work. What we don't have to do is we don't have to ask a lot of questions about what distances do you prefer? Are you a very exacting person? If it's not perfect, will you be disappointed? Are you laissez-faire? Do you mind just having 20/40 vision as an outcome? You know, you don't have to ask any of those questions. So if I'm operating on a nurse auxiliary from the NHS who earns £22,000 a year, or I'm operating on an airline pilot who earns £22,000 a month, it doesn't matter. It's the same surgery. And we don't have to interview them about their job requirements because it's the same procedure. Actually, one size fits all, with the exceptions that you'll learn about later. So that's nice. It's a objective test, well, okay, subjective, objective test that you do on the chair for 2 minutes. That's the plus 150 acceptance test. And that's it. They're a candidate, done. Now you start describing the counseling process and setting the expectations and building the patient's confidence that they're doing the right thing and choosing the right procedure. The procedure, we talked about it yesterday. It's called LASIK. It takes 8 minutes in both eyes. It heals in 3 hours. Any unusual intraoperative situation is usually completely manageable. And Bob's your uncle. So that part you already know. And then there's the post-op management, which has to be, which often involves a series of reinforcement of what was discussed before, because as we all know, patients retain 10, 20% of what you tell them at one visit. And so there has to be a lot of, well, if you remember before surgery, we discussed, if you remember before surgery, yes, that's normal. Yes, that's normal. Remember we said it takes about a month to heal. Today's day 1. Yeah, okay. So these discussions have to be brought up because that's how the human mind works. When it's anxious, it does not absorb information. So I hope none of you are anxious right now. Okay. The fact is you need to provide, as part of the package, and we believe that anyone doing Presbyond should be able to provide have a local, an arrangement with a local optician so that you can make quick and dirty, cheap glasses. Most people have their own frames, and so you can take their own frames and just send them next door, and you make a deal with your optical shop, and they'll make lenses up for nothing, basically. You pay, because it's going to be bulk, right? It's going to be, I don't know, I think it's about 5% of the patients we will make up spectacles at the 1-month visit. Now, it's a tiny expense, but the fact that you're doing it for them is part of the service. And the beautiful thing about Presbyond versus diffractive optics is that you can instantly reverse any discomfort by a pair of glasses. So if someone's not neuroadapting with multiple images in one eye, they can close the eye, but apart from that, there's nothing you can do. Whereas in Presbyond, any imbalance is instantly reversed by a pair of glasses. Come on, let's all do this together, just like that. It's like a magic trick. Or, if they were previous contact lens wearers, boop, and that's it. They feel good. And the point is that this adaptation can be enhanced by titrating the effect that needs to be acquired over the next few months. Okay? So I'm just giving you little highlights of a lot of the things that we're going to talk today. And then there's going to be dissatisfied patients because it's the human race and we get all kinds. And that obviously comes to the pre-op counseling and making sure that everything's documented and having continuity. So you need to try and do what we do, which is that the optometrist does the work before surgery, Surgeon, post-op visit day 1, everything's fine, back to optometrist. The same optometrist sees that patient throughout the whole journey. Yeah? If you have a situation where you're swapping optometrist and anybody comes in at any time, then the optometrist seeing the patient at the 3-month cannot say, well, I understand, but if you remember, we talked about this before the surgery, and we talked about it when I saw you in January. If it's not the same optometrist, and they say that, well, you know that we would have, we mentioned this, they go, no, no one ever mentioned that to me. No one told me that it would take 6 months. No. And no one told me it would still be blurry. No. And then you can say, well, I mean, I've got my notes here, and I did mention it. It's okay if you don't remember it, but you can go over it again. The power of continuity in this sort of scenario. And finally, you have to become comfortable with enhancements. And we had a lovely discussion last night on no names mentioned or countries, but how people are genuinely anxious about lifting flaps. And they want to do PRK on a flap. And it's like, not necessary. It just isn't. I mean, you can do the lectures that we did yesterday again. You can trust me. We don't like complications at London Vision Clinic. We're kind of like avoid them. And we do a ton of enhancements. So, I don't know, put those two and two together. We are fine with enhancements. We are fine with the process of managing epithelial ingrowth, which only occurs in 1 in 20 eyes if you enhance using the instrumentation and technique that Glenn spoke about at the end of yesterday. Again, everything is standard operating procedures. If you copy what we're doing, you're going to get the same results because humans are all the same on the cornea, almost, right? African cornea is a little bit thinner, I found out. And there's evidence in paper on that. Okay, so that's basically it. Now, I'm going to make a word, I think it's important, even though this is an academic course, part of the academics of refractive surgery and the World College of Refractive Surgery recognizes this. And that is that the reason why a refractive surgeon is different from other surgeons, from other ophthalmologists, is that refractive surgeons have to also be businessmen and women. They have to understand marketing, sales, ROIs. They have to really understand the process of the business that they're in because it's a marketing-driven specialty. Okay? So pricing is something that becomes very simple. And I have a colleague in Romania, Andre Filip, who came to our course. He was, again, one of these people who was like, Dan, I'm so happy with my clear lens exchange. This ice trifocal is incredible. I put it in my mother. It's amazing. Everything's fantastic. I really don't believe in the cornea. It's not right. I just want to learn SMILE. He comes to the course. He goes back, gets rid of his Schwind, buys a Mel 90, and now he says, Presbyon is my favorite procedure out of all of the surgeries that I've ever done in my entire career. And I love it, and I did it to my brother, and I did it to my brother-in-law, and I can't wait to have it myself. And so he's one of those. And Andre, what Andre did, and this was curious, because he said that he charges more for Presbyon than he does for a bilateral clear lens exchange with trifocals from Zeiss. I'm like, I charge the same. You charge more? Okay, how does that conversation go? And he said, it's very simple. The patient says, why is Presbyon more? I say, because you get better vision and because you maintain some of the accommodation that you still have in the eye. You don't remove that along with your natural lens. End of discussion. Why? Why will a woman pay $5,000 for a plastic bag? Why? Because it says LV on it. It's plastic. Okay, there's a little bit of leather around the edge, but it's basically a plastic bag. perception is value. And so in refractive surgery, the perception is important. Because you have a lower risk procedure that's more accurate with less side effects, that is adjustable and reversible, it costs more than a procedure that is lower risk, higher risk, less accurate, with more side effects, not adjustable and not reversible. It totally makes sense. So, the best way of talking about this for me is to talk about me. And my vision was interesting because when I was 17 years old, yes, it was 1979. It was at the height of disco. And, you know, John Travolta and, you know, Saturday Night Fever, it was all happening right there and then. And and I don't know if some of you guys here remember, but we used to put a little bit of eyeliner on. Do you remember that? It's nuts. Anyway, whoo. Yikes. Anyway, not that, you know, anyway, so as you can see, that was about, so there's basically 40 pounds ago. And you know, my refraction was absolutely zero everywhere, and I had 20/10 vision, and I had 20/10 vision for years, and I worked at Club Med. So some of you know what Club Méditerranée, the French organization that had, they're now owned by the Chinese, but they were kind of like, you know, well, I didn't realize it. I got a job in the band playing, you know, in a top 40 band in the evenings. And when I went, I was just interested in, you know, playing the saxophone, and I didn't realize what this place was about. And it was, well, as you can see from the hand around my waist, it was a very interesting time in my life. I learned a lot. But, you know, time goes on, and the pounds start, you know, gathering 1 pound per year. So 20 years later, you're 20 pounds heavier. That's my life anyway. And as I was aging, what was happening was that I was myopicizing slightly. Okay, so my lens was probably myopicizing, yeah? And it was when I was 53, and I was talking about this last night, I actually didn't realize I was a little bit myopic because my uncorrected vision was 20/30. And in the room with a chart at 2.5 meters, I could see the 2012 line. And I wasn't thinking that there's a divergence involved here, and it's like, I could see 2012, that's not a problem. And then here I could read J1. I was like, wow, I'm 53 and I can see 2012 in J1. That's because God gave me more accommodation. Because I've been fixing so many eyes, then he said, you can have more accommodation. You know, it's a bell curve, and I'm at the top of the bell curve in accommodation. Not weight control, but in accommodation. And so I looked for all these rejuvenating procedures, and, you know, can you, like, reverse aging? Can I reverse presbyopia? Phacoersatz, you know, lens filling, forget about it. It's not even decades away. It's more than decades away. And I have a fully equipped, this is an old picture actually, because we now have the Artivo instead of the Opni 700, but we have Centurion, we have everything in our clinic. And we have access to any lens we want in Europe, which is way more than the Americans have. And obviously, there's an obvious choice, right, for me, right? There's an obvious choice, and 99% of my colleagues would have said, no problem, Dan, you'll get a great result. But the problem is trying to, you know, reach the goal of all of the things that we want out of a vision correction procedure. And that's good contrast, good optical quality, binocularity, stereo acuity, you know, short adaptation time, obviously correcting the refractive error at the same time, including the cylinder, accurately, and being able to, if there's a complication, manage that complication, because, you know, there's always complications. So there's always a compromise somewhere with any of the solutions that are currently available for presbyopia. The other thing is that I was 50. And so I had still about 2 diopters of accommodation. It wasn't enough for reading, but I still had 2 diopters of accommodation. And if you look at all of these EoF lenses, they only give you about 0.75 or maybe 1 diopter, but mostly about 0.75, which is why the Symphony you can't read with it, and the Eyehance you can't read with it, and the Vivity you can't read with it unless you put a little myopia in. So you're taking out a lens that has 2 diopters and you put one in that has 1 diopter. What the hell's going on here? That makes no sense whatsoever. So retaining the accommodation that you still have is a huge benefit, because it's an adjustable amount that your brain just adjusts automatically wherever you're looking. And so given the amount of accommodation, look, a 45-year-old will have 3 diopters of accommodation on average. So that age group, even a 60-year-old still has half a diopter, 1 diopter of accommodation. It's not 0. And so there's still a little bit of play and adjustment that the eye can do if the lens is still in the eye. And there are various studies. The Duane graph is the most famous one, but Jackson plotted this as a scattergram. And what's interesting about looking at the scattergram is that you can see the outliers. So you can see that there are 56-year-old, with 2.75 diopters of accommodation. So it depends. It's not just one number, it's not a straight line. So if we, for the purposes of this talk, we think about the correction of presbyopia as the addition of 3 diopters to the eye. It's either 3 diopters of focus, or let's call it, in this case, 3 diopters of depth of field, okay? So if we could have a procedure that could deliver 3 diopters of depth of field into each eye, then you can have distance and near, and that's Bob's your uncle. And if it's depth of field, it's continuous. It's not discrete like multifocality is. And so we come to this eternal existential battle between the titans. And this has been going on for years, and I've obviously been in the middle of it. And that's this thing about cornea versus lens, and you hear the stories. I was at a meeting in China, and with a small group afterwards with the big professors, and the first question was, I don't understand why, if presbyopia is a problem of the lens, why you would operate on the cornea. The lens is the problem. And it was like, you know, cornea versus lens. And a lot of people say, no, no, no. Cornea doesn't work for presbyopia. You can't go to lots of websites. It says, cannot have laser eye surgery for presbyopia. So everyone thinks that it's 2 different planets. And these people don't speak the same language. It's Vulcan and, you know, Cardassian, and they don't connect. And they can't talk to each other. And they're just arguing and arguing and arguing. I'm going to tell you, this discussion is not 2 planets. It's 3 planets. And it's not cornea versus lens. It's multifocality, more than 1 focus inside 1 eye, spherical aberration to produce extended depth of field, that's another planet, and monovision. Those are the 3 planets. And we have to understand that multifocality has been in play for about 20 years, and the original array lens that became popular among some had such high side effects that the industry started to decrease the multifocality to increase patient tolerance and improve safety. And then they came up with other lenses that had less multifocality but less function. Monovision, of course, Graham Barrett, big proponent of modest monovision. And in cataract surgery, you're putting IOLs that are spherical, so they have spherical aberration. So guess what? When you do a little bit of monovision in a cataract surgery with a monofocal IOL, as long as it's not aspheric, if it's a spherical lens, you actually get depth of field. And it works pretty damn well. And he didn't realize that this was the reason, but he was on the stage all the time speaking against multifocality and for a mini monovision monofocal cataract surgery, because he was observing that patients had an incredible range of vision without circles around lights at night. And that was interesting for me to watch, because this is before the idea of depth of field by spherical aberration was really sunk in to the community. And I was not willing to put in an array lens or a restore or a resume. I just wasn't going to do one. I wasn't going to do one. Even though, mix and match and blah, 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 zero. So I was stuck, and I felt there has to be something better. And as I will explain later, came across this idea of using spherical aberration to increase depth of field and therefore improve on monovision. And I thought I was going to improve on monovision by adding depth of field. And what ended up happening was I ended up actually with binocular vision that was modified. So it's not even monovision anymore. We don't use the word mono. We don't say micro-monovision like we did in our first paper in 2007, 2009. Now we don't use the word mono. We could take it out of the vocabulary because it's not mono, it's binocular. And this depth of field, and what I'm showing here is the way that the entire galaxy of these 3 planets, both the multifocality and the monovision camps, are converging into what is the original way that we started doing this in 2004. And that is extended depth of field by spherical aberration modulation with a small anisometropia. Everything is converging to that now. All of the companies, all of the lens manufacturers, everyone. And so, even though I say so myself, I hit on the right answer, let's say by mistake, by serendipity, in 2004, and I've stuck to my story, and now even the corneal multifocal procedures are starting to back off on their multifocality to make it more like Presbyon. And we have all these IOLs that are coming out that are basically trying to mimic Presbyon. So, just to say, this is nothing new. It's been around since 2004. It's been a Zeiss product since 2009, and we're about to find out why. So let's talk about monovision. We have to understand each of these modalities well. Monovision has disadvantages, and there are 5 of them. First, you don't have any intermediate vision, or you have any near vision if you give more intermediate vision. Second, only about 50 to 60% of human beings can tolerate it. Third and fourth, there is loss of summation because it's one eye for distance now. So the other eye is not contributing at distance, so you lose the summation in the brain. And many individuals get cross blur, and that's called neural subtraction, where a patient will see better if they cover the non-dominant blurred eye than if they uncover. So in other words, as soon as they have introduced the blurred eye, the circuits take away some distance vision from the other side. It's called neural subtraction. And in proper monovision, you lose stereo acuity. And it's not like you lose it while you're wearing it. You lose it and it breaks, and it's a brain thing that gets unplugged, and you can't plug it back in. So once you lose stereo acuity, you can't have it back. I was intolerant to a -175 difference between my eyes, but I was tolerant to a 150. And you will find this in your practice. This 150 is a magical threshold which we arrived at because almost everyone has that tolerance. And we're going to go through the tolerance test. You'll understand how that works, and then you'll also understand what we do when they're not tolerant to 150. But I had what we call minimum cross blur at 150, and so this monovision story has been constantly evolving from full monovision to reduced monovision to now spherical aberration depth of field with binocular vision. And like I said, Graham Barrett has been very vocal against multifocal IOLs because he gets similar results with monofocal IOLs and a small monovision. But of course, if you have a small monovision, then you have less near vision. Now, this graph is one of the most important graphs of the entire day. Okay, so this is This is really important. This study by Pardon, which was published in 1990, what they did was they looked at summation and subtraction, neural summation, neural subtraction. And so here's your 2020, 2016, etc. And here is the anisometropia between the eyes. Okay? So if you have 0 anisometropia, like both eyes are set for distance, and both eyes are 20/20, you will actually see 20/12 on average, because there is more vision, because there is neural summation. As you increase the anisometropia, the summation decreases, and interestingly crosses the line at about -1.3 diopters. Beyond -1.3 diopters, you get neural subtraction, and by the time you get to full blur on one side, you get suppression of that eye. And if that eye is fully suppressed, that means that the other eye is not impaired. When it is not suppressed fully, it confuses and subtracts. Okay, does that make sense? So this is the neural summation curve, and this is very important to understand because presbyon operates in this range, right here. Okay, stereoacuity, there are 2 studies showing that if you give monovision of -150 or more, this is with contact lens monovision, then you will lose 4 to 5 patches of stereoacuity, and for 1 year, and then at the end of the year you take off the monovision and the stereoacuity does not come back. So it's a permanent break, unrecoverable. So to not do that, you need to have an isometropia of less than -150 to not lose stereo. But then in monovision you don't have enough near vision. So that's the problem with monovision. And so this reduced monovision works and it keeps your stereoacuity, but you don't have as good near vision. We come to extended depth of field, and what that does is that it takes care of all of these disadvantages of monovision because it's now binocular vision, which is modified. So modified binocular vision. And that's what presbyon is. Actually, many people who started using the word blended vision, I think it really originated from Dan Dury in his EoF thesis. Blended vision is when there is sufficient information from the more near set eye that the brain can still fuse the 2 images and produce stereoacuity, produce binocular perception. And presbyon is modified binocular vision, and that is really, really different from modest monovision, okay? Just got to be very clear, this is not mini monovision, this is binocular vision. So, let's talk about how this works. What is spherical aberration? Well, I don't have to tell you that, you're all ophthalmologists and optometrists and scientists, but I'll just say briefly, remember that spherical aberration means that the focus changes with the aperture. So optometrists know about night myopia because they have to prescribe glasses in young people that are slightly over-minused because when the pupil gets larger at dark, the eye becomes more myopic. So what they do is they'll prescribe a plus 0.5 or plus 0.75, which a young person can accommodate fine during the day. And then when the pupil gets larger and the patient myopicizes by 0.5 or 0.75, then the glasses are in focus. And Zeiss had a whole thing with their eye profiler where they were measuring spherical aberration in the refraction, and they would calculate, based on age, what the prescription should be for that patient. Blah, blah, blah. It's a naturally occurring aberration. So when we're young, we have no spherical aberration. Our lenses are exactly balanced by the spherical aberration of the cornea. So the total eye spherical aberration is 0. In fact, in your 20s, your spherical aberration is 0. When you're about 80 years old, and we've looked at all this, the spherical aberration of the eye is about 0.6, between 0.6 and 0.8 for an 80-year-old. Why is that? Because the lens becomes more spherical, yeah? Aging causes the lens to grow, right? The lens growth continues throughout our life. And that's the reason why accommodation stops working about halfway through an 80-year-old's life because of lens growth. The other thing is that you now understand, of course, that if a lens is aspheric, but then you accommodate, the accommodation process makes the lens more spherical, which means that the spherical aberration goes up. Right? So now spherical aberration is not an aberration that is alien to the software image processing system of the brain. The brain understands how to filter spherical aberration. When you are reading, you don't see blurry edges because you have more spherical aberration. Why? Because you're filtering it. Okay? When you're older, like me, you look at the sky, well, now I have presbyon, but you look at a star and you don't have more spherical aberration that you perceive. You still see a star as a dot. And that's because you adapt, you filter the spherical aberration, and there's a difference between the image on your retina, which has a spherically aberrated star, and the image in my mind when I'm perceiving vision. That is an image processed version of the retinal image. Okay? So quite clearly though, let's go back to this thing. It is not multifocality, right? Multifocality is multiple foci. So more than one focus in the same eye. This is an aberration that is continuous, and if you took a letter and increased spherical aberration looking at the edge of that letter, the edge would just get more and more blurred. And the kind of blur, if you were to look at the blur in cross-section, is a very specific kind of blur which the brain can filter. Coma can't be filtered very well by the brain. That's why humans deal very poorly with decentrations in refractive surgery. So in your perfect aspheric system, there is focusing at exactly one point, and just in front and behind it, it's out of focus. But with a more spherical aberration, then the focus is slightly, blurred, it's slightly disconnected, and therefore there is a similar amount of focus in a larger range in front and behind the actual focus. So spherical aberration is like a circle of Strum in spheres, right? The aberrations, which I'm sure, well, I hope everyone in this room understands, tip, tilt, and piston, but these are sphere and cylinder. And then the third orders, trefoil, coma, trefoil, and then the fourth order aberrations. And spherical aberration is the next order above sphere. And then you can have spherical aberration at the 6th order, and the 8th, and the 10th, and the 12th. And it just ends up with more and more kinks in the Mexican hat. Just like we can have quadrifoil, which is, secondary astigmatism. Now, this experiment is, we're going to do this experiment here in this hall. So at the top, you see what would be the chart defocused by a certain amount of sphere. And on the bottom, you have the same defocus, but now with spherical aberration also in the convolution of the image. And what all of you here in this room are doing is you are filtering the spherical aberration, and you are able to edge detect inside that edge of blur because your brains filter spherical aberration. If this was coma, you wouldn't see these letters as well. But with spherical aberration, you can, because it just happens to be the one, like it's the Photoshop module that you actually have as part of being a human being. So as you can see, spherical aberration adds edge detection ability, which we translate as depth of field, although it is not depth of field in the optical sense. In the optical sense, depth of field would be, a pinhole, which has only one ray of light from every object, and therefore there's infinite depth of field. We use the term, although it's not strictly correct. The point we're making here is that you can see more than you would have at that level of defocus. So we're calling it depth of field. Now, the brain filters, remember? So let's say that we have some spherical aberration at plano in the right eye and at minus 150 in the left eye, and you're saying, well, the brain has to put these two images together. No, what's happening in the brain is that this amount of spherical aberration is made totally sharp by the brain. My distance vision, I'll show you that, is 2010 in my distance eye. It's so sharp. And my non-dominant eye, which is minus 175, I see 2040 with that eye. No minus 150, no minus 175 eye on the street can read 2040 on a chart. None. I have way more edge detection than you'd expect for that refraction. So in presbyond, actually, the reason why 97% of people are candidates for presbyond without asking them any questions about their profession is because you're not asking the brain to put much different images together. They're just very similar. And so the brain just puts them together. Whereas in monovision, you're asking the brain to put these two images together. And as you can see, that's not as easy. Okay? Remember that this non-dominant eye, usually, is set to minus 150 with the spherical aberration, but there are other elements helping us. First of all, there is meiosis, right? Even a 70-year-old who has no accommodation left, when they look up close, have meiosis, right? Well, unless they have neurosyphilis. But basically, that will happen. So that's an advantage that we can add in. Combining these two gives you an aberrated image delivered to the brain, which the brain then filters by central neuroprocessing, and the perceived image in our mind is sharper. So how did we get to this spherical aberration concept? And I am not an optical scientist, but I did a little bit more engineering than most people because I did ultrasound research in a biotech lab, bioengineering lab in Cornell for 4 years during my training. And I was always more mathematical in physics, and maths and physics were more interesting to me than, bacteria and, stuff like that. I was much more interested in numbers. So when I decided to move back to Europe in 2001, along with a contract with Meditech to help develop the MEL 80, which was called the REFCO at the time, they had the highest resolution wavefront sensor in the world. It was called the COAS, made by Wavefront Sciences in conjunction with Meditech. They developed it together. And it had 600 spots in a 6mm zone, which was 4 times more than the next best aberrometer, which had 180 spots, which is the Vuzix. And the Bausch & Lomb had 70 spots. So they were so far ahead in terms of the resolution of their wavefront sensor. And I came to Europe, and of course, during the 90s, we generated so many patients with night vision problems because ophthalmologists didn't know anything about spherical aberration, and we were doing LASIK and multi-zone. Like we're going to do -5 and a 5.5, then we'll do another -1 and a 6, and then we're going to do a -1 and a 7, and that'll treat -7.5. And we were doing all kinds of stuff. We had no idea what we were doing. And we generated a lot of cripples, visual cripples at night. And so the first thing I wanted to do when I got back to Europe was to fix people with night vision disturbances. And we did this study where we took patients that had had surgery with spherical profiles, right, like the Vuzix 2020B and the Vuzix S2, spherical profiles, and had a lot of spherical aberration. And what we did was, of course, they had night vision disturbances, and what we did was we measured their wavefront, and then we put the wavefront, the inverse of the wavefront, on the cornea, so that we're trying to reverse the higher order aberrations. In order to control for the group, what I did was I took 4 eyes that I had treated on the MEL 80 that had the same pre-op prescription as the eye that had the night vision disturbance, but were treated on an aspheric profile called the ASA profile on the MEL 80, and they didn't have night vision disturbances. So a -4 in the study with 4 -4 eyes that had a modern wavefront optimized treatment and did not have night vision disturbances to compare, because even aspheric profiles still increase spherical aberration, right? So these aspheric profiles do not stop the induction of spherical aberration, but the normalized contrast sensitivity ratio doesn't change in those patients. And what we found was that we only got a 27% decrease in spherical aberration. And looking at the number, it was very disappointing, because somehow the companies had told us that we were going to flatten the wavefront. And this was so far from flattening the wavefront that it was like, what's going on here, right? The promise was not, it was a bit of an overpromise. But what was shocking was that the patients were coming in saying, oh my God, doctor, you completely fixed it. And I was like, what did I fix? The night vision, it's amazing. I see so well at night. Even the day after the surgery, I was looking out and there was just no halos. Everything looked fantastic. Good, it's good. Would you like some tea? And so guess what? Their normalized contrast sensitivity ratio went back to normal. And they had good night vision. And that's when the penny dropped. Ready? The penny dropped. And I was like, wait a second, wait a second, wait a second, wait a second. They have tons of spherical aberration in their eye, but they see perfectly at night and their contrast is normal. We can use that. And so I said to Tim, let's look at the cases and let's look at what is the maximum spherical aberration that we are leaving in these eyes. And so we looked at it and we said, well, the average is 0.56 microns. So we said, let's round it up to 6. And let's just say that 0.6, for now, let's call 0.6 a limit above which we do not want to have, because it seems like people can filter that stuff. They get normal contrast, their night vision is fine, with all that spherical aberration in the eye. And when I was presenting this at the ESCRS, I think a year later, Pablo Artal, you know who Pablo Artal is, he's one of the top brains in visual optics on the planet. He came out and says, this is not going to work. That's way too much spherical aberration. It's totally going to affect contrast. He was like all over me like a rash. And the next year, when I was presenting these outcomes, he came out to me on the stage and he said, you know what, I think you're onto something. I think this is a very clever idea. And actually, he has developed an IOL called the ART IOL, which has 0.7 microns of spherical aberration in it. So something that he would have never done, but because of clinical experience, he's now realized is a good idea. And that level of 0.6, interestingly, translated. In the meantime, by the way, this is several years later, this is 2012, but look at this paper by Antonio Lescotti with one of his fellows, and they were noticing that the control group of patients who had hyperopic PRK, who did not have hyperopic PRK, saw less well up near than the group that had hyperopic PRK. So they were steepening the center of the cornea, right? So when the pupil gets smaller, the center is steeper, so that's called positive spherical aberration, right? So more myopia as the pupil gets smaller, and so they were getting a reading effect. Now, maybe, maybe not. And this is something which was, who was on the Gerso call on Sunday with me and Gatinel? Who was there? No one? Oh, wow. No, so one of you was there. We were talking earlier. Yeah. Anyway. Oh, you were there. One word, describe it. That was 2 words. No, it was cataclysmically nuclear, the discussion. And it was actually, we had to stop because it was actually like, oh my God. We downloaded it actually, and if you're interested, we could share it on a secret channel. Anyway, because it's the debate between focus changing with aperture and what the brain can do with spherical aberration. And we seem to be on 2 separate planets. I'm speaking Vulcan, and he's speaking Cardassian. And it's just not, we're not able to communicate. But anyway, around that time, and he's very smart, so he will get it, but I'd like him not to get it because it holds Alcon back. What happened at the time was I started presenting this concept, and there were 4 labs around the world, Rochester, Cleveland Clinic, that had adaptive optics devices. And with an adaptive optics device, you can have someone look through the machine, and you can put aberrations into the pathway, and then include the brain in the process of vision, right? So you can measure the depth of field through different aberrations. And one of the studies, Carolina Rocha, she was Ron Kruger's fellow in the Cleveland Clinic. She published this paper, which I love to show because it's beautiful. And as you can see, this is spherical aberration, which is either positive, where as the pupil gets smaller, the eye becomes more myopic, or negative, which is as the pupil gets smaller, the eye becomes more hyperopic. In optic world, ray tracing world. But what she showed was that the depth of field increased, whether it was a positive increase in spherical aberration or a negative increase in spherical aberration. This slide shows you that the mechanism of presbyon is not related to the optical ray tracing aspects of spherical aberration. Those aspects, in theory, would act against presbyon if you're doing it on myopes. Because the myopes, you flatten the center, so you have more hyperopia in the center as the pupil gets smaller, right? So if you're going to just do a ray tracing argument, then you would say, this will only work on this side. But I'm just showing you peer-reviewed evidence that shows that negative spherical aberration gives increase in depth of field also. I can't do it better than that. That's as far as I can go. So what we know, and Glenn had this nice idea of giving us a drug analogy. So most drugs come in, certain doses, and, paracetamol is, 500 milligrams. I mean, that's it. You can either buy 500 or 1,000. You can't buy 425. It's 500. And if you're big and fat or short and skinny, and you have big liver or a small liver, you get the same 500. So why is that? Because that one 500 tablet will put your blood levels in the therapeutic range. And it won't be toxic. It won't be too little, so you get no effect, but it won't be toxic. And that's why those pills come in 500 only. I mean, you can get 325s, but okay, let's not argue here. You understand what I'm saying? So the same with spherical aberration. We have a therapeutic range and a toxic range, okay? We know from our study, where that gave us the idea, that these patients had toxic levels of spherical aberration, and all we had to do was to nudge it down 27% into this range, and like magic, the spherical aberration effect went away because the brain was filtering it. So we got on with this straight away and started publishing. Our first paper was the hyperopia paper, which was 2009. Then we came out with the myopia paper, and then we did the emmetropes. And in the emmetropic study, we also studied the adaptation curve, because those are the patients that adapt the slowest. So if you're going to do a study on this, you might as well do it on the worst candidates, and then the others are going to just be better. or the same. Before we talk about this, let's just review here, just a quick review of everything we've been talking about, which is that if we are to increase the depth of field in the cornea without affecting contrast, we can only go up to 0.6, 0.6, 0.7, something, whatever, around that, plus or minus. So that turns out to be an equivalent, and you'll have to take my word for this, of minus 150, of a 150 diopter depth of field equivalent. Okay? It's not 150, it's not 100 diopter of ray tracing optics. It's that degree of depth of field. Okay? So because it's only 150 and we need 3, we have to do a little bit of anisometropia to cover the whole field. Is that really clear now? That has to be clear, yeah? Any questions about that, just to understand? Okay, so what does the Presbyond software do? Well, the inputs are the patient's age, the patient's functional age, which means a 52-year-old with 3 diopters of accommodation has a functional age of a 45-year-old. A 39-year-old with accommodation of 2.5 diopters has the functional age of a 48-year-old. So, and we see this. I mean, we see people who develop presbyopia very early and people who are not presbyopic very late. Yes, they could have small pupils and other factors. Anyway, I'm just saying, what does the software do? It takes in those parameters. It also takes in what the current spherical aberration of that eye is. So dilated, 6 millimeter zone, total eye, whole eye spherical aberration. It takes into account the sphere in the cylinder and the optical zone that you're going to treat the ametropia in. And it, with the algorithm, takes all those numbers, and what it does is it takes this eye, which came to us with plus 0.2 spherical aberration total, and makes sure that even if you're treating that minus 8, you don't go above the threshold. So the software then puts into the profile anti-spherical aberration increase juice so that less spherical aberration is induced on that eye and puts it in the therapeutic range. If you'd have a hyperope with the same spherical aberration pre-op and you do the hyperopic ablation, it just goes in the other direction. Okay? And if it's an emmetrope, then actually you're getting probably a mixed effect of the spherical aberration maybe going in one direction with one eye and the other direction in the other eye, but it doesn't matter, right? Because it doesn't matter if it's positive or negative, it still has depth of field effect. So, what do these profiles look at? This slide is from 2004, and this is from the old CRS Master software where you can look at the profile. This was the profile of a -5 treatment with the nonlinear aspheric profile that we designed here, and this is a standard aspheric profile, the wavefront optimized. So you see it's a little bit more tissue, and the shape is different. So, but what I want you to be very clear about, and I want you to tell all your friends who don't understand this, it doesn't have any discontinuities or weirdness. It's not some weird profile with a little nipple at the top, okay? It's not a breast. It's a baby's bottom. It's smooth. There's no kinks. There's no bumps. There's nothing weird about it. It's a very natural profile, and therefore the topographies look normal after the surgery. So this is what this cornea looked like after that treatment with the Presbyond software, after that treatment with the Presbyond software, after that treatment with the Presbyond software, after that treatment with the Presbyond software. Nothing weird at all. You will never be able to distinguish a Presbyond eye from a regular LASIK eye, except that the spherical aberration will not go above plus 0.6. Okay, not. I mean, that's what you try, right? It's biology. You always get outliers. That's the difference between presbyond and all of the other corneal methods of correcting presbyopia, which induce central steepening. Minus Q5, setting a Q slider to minus 0.6, if you treat a minus 5, you're flattening the center by minus 5, but you want the center to be steeper, because that's minus 0.6 Q, so you have a central island to make the center steeper. Presbymax, add in the middle. Supercore, add in the middle. Raindrop, add in the middle. Everything is, what Susan Jacob is taking a punch out of a lenticule of Smile and putting it in the middle of the cornea. These procedures are steepening the center to cause an optical ray tracing type effect of more myopia as the pupil gets smaller. We are not doing that. Presbyond is not doing that. It's working on spherical aberration and neural processing. So Sri Ganesh's paper on presbyond, and he showed these changes that we expect to see on spherical aberration. This is our data. Here's almost 30,000 eyes, and this is the spherical aberration. And this to show you what spherical aberration is in the population. And what's interesting about this is that in myopia, you notice that the higher myopes don't have more or less spherical aberration than the lower myopes. But in hyperopes, as the hyperopia gets really high, actually the spherical aberration increases. And that's understandable because partially they have smaller eyes, so their lenses are probably more spherical, so they have more spherical aberration. It all makes sense. And their corneas are flatter. It all makes sense, right? It all makes sense. This is the distribution of spherical aberration in the population, right? So half of the population has no spherical aberration, et cetera, et cetera. But practically no one has the desired amount in this population of people that have come to us for surgery. In other words, 18 to 80. So back to this diagram, we need to use a little bit of anisometropia because we can't cover the 3 diopters without compromising contrast. And so what happens? So let's just look at this from a ray tracing standpoint, like in the focusing world, the visual optics world. What's happening is that the dominant eye is set for plano. But remember, we have a 1.5 diopter depth of field around that plano, which means that the front of that depth is plus 0.75, not very useful. But the bottom of it is minus 0.75. It's set to plano, but at near, it has minus 0.75 equivalent of depth of field. The non-dominant eye is set to minus 150, but at distance, the half of the 150 takes that non-dominant eye to as if it was minus 0.75 at distance, but at near, it's as if it was minus 225 at near. You see that 150 bracket on the non-dominant eye is centered on 150. That eye therefore behaves like an eye that can see minus 0.75 to minus 225, and this eye sees from plano to minus 0.75. And that's why both eyes have approximately the same acuity in the intermediate. And that is the blend zone, and that is why we have binocularity. Because the distance vision of the non-dominant eye is so not blurred, even though it sees like it's minus 225 at near, that the brain fuses the 2 images, like I'm fusing my 2 eyes right now, completely. I see everything binocularly. So, just to recap, because I like to hammer this home, because there's so much confusion about it. If you do a multifocal cornea, you're going to have more than one image in the same eye, and you're going to require your brain to resolve intraocular rivalry. Intraocular rivalry. Whereas in disparity between the eyes, you're asking the brain to deal with interocular rivalry. And the brain, as we know, is wired to do interocular rivalry in monovision in 50 to 60% of humans. So if you're making that interocular rivalry very, very mild, well, now you understand why 97% of people that walk through the door into our clinic with the plus 150 acceptance test pass the test. We don't even have to know if they're an airline pilot or a toilet cleaner. It's the same treatment. Well, toilet cleaners, they have to be able to see very small things like bacteria. So, okay. So, I have people coming to me and saying, Dan, it's all very clever, but I've been doing Plano minus 150 for years with my Vizix 2020B, S2, S4, iDesign, Wavelight, Schwinn. And it got the same effect as you're talking about. Why do I need the Presbyon software? I'm already doing it. And I say, you're right, you are getting that effect. But see, the difference is that if you just do it like that, then the percentage of eyes that will be inside the therapeutic range won't be as high. Because you have a generic profile that is inducing spherical aberration to correct the ametropia. And yeah, a lot of them are going to end up in that range between plus 0.3 and 0.6 or minus 0.3 and 0.6. But you're going to have eyes that overshoot or undershoot. And what's nice about the Presbyon software is that you push one button and it calculates a profile that has the best chance of putting that eye in the therapeutic range. So yes, you get a lot of patients that have the same effect if you just do monovision LASIK with the same Plano minus 150 targets, but you get more eyes in that range with Presbyon. Not all eyes, come on, it's biology, you know, there's outliers, but more eyes. And one of the nicest things that I love it when I get a call or a surgeon, an email from a surgeon who started Presbyon. One of the things that I love to hear the most from them is when they say, you know, you said it wasn't monovision, I went to the course, you made it convincing, but I just couldn't really, and I'm telling you, it's not monovision. It really isn't monovision. Because what happens is that the patients on day one barely notice the difference between the eyes, straight away. And then it kind of happens a little bit over the next few weeks, and then, you know, whatever. But it really isn't monovision. So the results that we got, and we published these, this is more than 100 patients in each group, and it's myopia up to -8, hyperopia up to +6, and emmetropes. And this is like an FDA trial. We had more than 90% follow-up at 1 year, including the enhancements. What were the enhancement rates? Now, this is where the competition tries to poke holes in what we're doing. So in our studies, which were myopia, hyperopia and myopia was done with a Hansatome, mostly, I think. Half of these were Hansatome, I think. And the emmetropes were all done with femto. Now, obviously, the enhancement rates with Hansatome are higher than femto, obviously. But if you look at the criteria for enhancement, we were enhancing eyes that were 20/20 or J3. In other words, if an eye is 20/25 and J3 after a multifocal IOL, no surgeon's going to do a laser on that because it's a perfect result. The difference between multifocal clear lens exchange and corneal refractive surgery is that you didn't go inside the eye and you can go from a good result to a great result. That's the difference. And in our practice, we believe strongly that because the risk of enhancements is so low and because epithelial ingrowth is not a problem, because it's manageable and we only have to manage it in 5% of the eyes that we lift if you do it according to the way that Glenn showed you yesterday, it's not a big deal. And so what we do is we send patients out the door with great vision, seeing tiny print in dark restaurants and seeing, you know, the birds in the tree a kilometer away. And they impress their friends and they send you more patients. So the way that a Presbyon practice grows is really exponential. It's crazy. It's way more. It's like the old days with LASIK. It's that hard. Whereas when you're having a patient have rings around lights at night that has to 6 months to adapt, by the time they're adapted, they're exhausted, and they tend not to refer that many patients to you. Whereas the next day, they're seeing J1, and they're like, this is incredible. My husband last night couldn't believe it. He's booking in tomorrow. Right. So these are the results, and we're looking at the 2020 J5 rates, that's newsprint, and we had 98% of the eyes at up to -8, including astigmatism, 95% of the hyperopes, and 97% of the emmetropes. Let's go for 2020 J2. That was 95% of the myopes, 77% of the hyperopes, and 95% of the emmetropes. Now, why are these results so good? Why have we been accused by a number of people to fake our results? Well, it's because we have a standard operating procedure for refraction. We have multivariate regression analysis models for our nomograms. We enhance anything that moves, and we manage the complications and end up with no safety issues. So this is the day one vision. So this is what we're talking about in terms of what you would expect in your room on the first day. So this is N5, which is J2. Almost 80 to 90% of the patients are seeing J2 on day one, and 80% are seeing 20/20 on day one, but half of them are seeing 20/16 and J1. That is, it's like a love fest on post-op day one out there, okay? This is a very, very different environment than, I have a surgeon in the north of England who took a long time to convert from clear lens exchange because he was working for a company that website said laser can't fix presbyopia, the only option is clear lens exchange. And then he left and formed his own practice and decided to adopt Presbyond. And he said, came up to me at a users meeting and he said, "You changed my life. I used to hate Saturday mornings because I did my private lens replacement cases on Friday afternoon, and I went to the office just dreading it because I had to deal with a huge amount of anxiety being projected onto me because of foggy, waxy vision, and reassuring it, it's going to take time, and remember we talked about it's going to be 6 months. He says, now I'm running to the office. It takes me half the time to do my post-ops, and I'm on the golf course at 1. He says, you've changed my life. So the point is, people talk about, adaptation being a problem, and there are some patients who are a problem, and we know how to manage those. But in general, those of you who have visited us and seen, the next morning is really enjoyable, and everyone's so excited. Because it's LASIK, because we're correcting the spherical aberration correctly, we get no loss of lines of 2. We get no loss of contrast. Actually, contrast goes slightly up, although it's not clinically significant. And although we were accused of faking our results, now there are many publications on Presbyond around the world where people are duplicating our results. And actually, they're doing things that we didn't publish originally. Like Shri is publishing the patient satisfaction rates, which are off the charts, and their spectacle independent rates, which are off the charts, and the dysphotopsia rates, which are like non-existent. Andrea Russo, same thing, came to the course 2 years ago, sold his Vizix and Intralace platform, which he had just bought, switched it with a VisuMax and a Mel 90, and reports exactly the same thing. Huge patient satisfaction rates, massively independent from glasses, and no dysphotopsia to deal with. So, let's look at some examples. These are very old slides. These are from 15 years ago. This is a 56-year-old female, slightly hyperopic, 2016 best corrected, normal contrast, 1 year post-op, plus a quarter, minus 1.25. Binocularly, 2016 J2. Okay, let's look at her non-dominant eye. It was -1, -0.5 at 20. That's a spherical equivalent of -125. and her uncorrected distance visual acuity was 20/60 in that eye. So her distance acuity was 20/60 for a -125. Sorry. A -125 eye is expected to see 20/60 without surgery off the street, okay? Guys, oh, there it is, okay. Her actual uncorrected visual acuity at distance was 20/30, which is an equivalent of as if the eye was -0.5 at distance. But her near vision is, her near vision is, there we go, her near vision is as if she was +2 in that eye, because for her age to see J2, she would need a 2 add, at least a 2 add. Okay? So she sees at near as if she has -2, she sees at distance as if she sees -0.5, and the difference is 1.5 diopters. This is why presbyond is not monovision. They have better distance vision than expected for the refraction and better near vision than expected for the refraction. And this was what I was trying to get across on Sunday at Gerso, that the world is not just ray tracing optics. There's a brain involved in the system, and it does things. So we take care of the intermediate loss, we take care, because look, this is 240 patients up to -12. All of them have font size 12 at the computer distance, up to +6. All of them have computer font 12. We take care of the anisometropia problem because monovision is tolerated by about 60% of humans, but blended vision, the vision is better at distance and near, is tolerated by 97% of patients. The distance vision loss and the summation loss are taken care of because there is summation. It's 395 patients, -8 to +6, including emmetropes. You can see that the non-dominant eyes, normally you'd expect a -150 to see 20/80 or 2100, but 80% of the eyes are seeing 20/60. So the distance eyes are 92% 20/20, but when you open the other eye and have binocular vision, they see 96% of the eyes see 20/20. So there's more vision with the blurred eye added than without the blurred eye. So there is summation going on. It is binocular. I was in a discussion one day with John Marshall about how this is working, and I asked him about is there a graph of, because he's a retinal pathologist, I asked him, what is the relationship between visual acuity and angular departure from the visual axis? And he said, you know, if you look in Adler's physiology, I think it's in there, and I have it. And I looked at it, and here's Wertheim, 1894, who showed that if you are 5 degrees off axis from the fovea, your vision is 20/60 at that point in your macula. Which made me do these diagrams. Imagine a retina, which is 2200 in the periphery, we all know that, which is 2063 at the 5-degree angle zone and 20/20 in the center. Now, in monovision, the whole eye is 2200, right? Because it's -250. In blended vision, in presbyond, the center is 20/20, and the 5-degree is 20/60. So it's very hard for the brain to put the foveas together, whereas, and that has to suppress for the patient to tolerate it, whereas in presbyond, it's 2200 in the periphery, but it's 20/60 in the center. And if you look at the retinal correspondence that you get with the other eye, there is retinal correspondence all the way inside the macula, including and down to the 5-degree field. So you understand, in monovision, the retinal correspondence is only in the periphery. But in presbyond, the retinal correspondence goes into the macula and down to the 5-degree field around the fovea. So there is more retinal correspondence And that must be something to do with the tolerance and the binocularity and the neural summation that we observe. The stereoacuity was done as a sub-study, and in this study we found that almost all of the eyes, basically no eyes lost best spectacle corrected near stereoacuity. And that's compared to 4 to 5 patches lost in monovision. Whereas uncorrected, without correction, in other words, with the distance eye seeing up close on the Randot test, 100% of the eyes had 400 seconds of stereo, and 3/4 of the eyes had better than 100 seconds of stereo, uncorrected. So blurred eye up near with good eye up near, stereo, proving that this is binocular vision, proving it. Reversibility. Well, what did we talk about earlier? You can reverse this thing with a pair of glasses. Boom. That's it. If you happen to be in the 5% of people who never adapt fully, you're spectacle independent during the day, you have your glasses in the glove compartment of your car, and you put them on to drive. Next, that's it. No big deal. I was one of those, and I thought I'd be permanently one of those. And at 18 months, I flew with Tim to Germany to go to Jena for our consulting day. And we land in Berlin late at night, and we drive 2.5 hours to Jena and go to sleep. And we got in the car, and we're bombing down the Autobahn at like 200 kilometers an hour. And I was like, oh shit, I didn't get my glasses out of my briefcase. And then I was like, wait a minute. I don't need my glasses. I don't know what happened. Out of the blue, because for about 18 months, I needed them for driving at 200 kilometers an hour in the dark. But I suddenly didn't need them. So I was a late bloomer, call me dumb, call me slow, but anyway, it worked in the end. And of course, you can permanently reverse this, or you can partially reverse it. You can titrate a patient down if they're not adapting. So there is an escape route. There's always a get out of jail card with Presbyond. Not always the case if you replace the lens. And we don't have to do wavefront guided or topography guided weirdness, bizarre profiles to reverse anything because the cornea is not multifocal. So in summary, spherical aberration EoF on the cornea or the lens gives us the ability to correct plano presbyopia and a wide range of refractive error. Let's be conservative and say +5 to -9, with correction of the cylinder at the same time, with the use of a natural aberration called spherical aberration, with centration on the visual axis of the spherical aberration, difficult to do with a lens that goes in the bag in an angle kappa eye, easily enhanced in the future as things may change, minimal compromise to night vision in contrast. Practically everybody who walks through the door goes through a extra 2 minutes of testing to see if they're a candidate. No questionnaires, no personality tests, and then it's done as an 8-minute procedure bilaterally that heals in 3 hours, and the patient is reading the menu that night with her husband, jealous, booking in the next day. So, any questions? Now, this is the trend, and let me talk about how the trend is real, because there are now extended depth of focus lenses on the market. And Graham Barrett caught on to this very early on. We had very nice chats about this, and he developed the Rayner lens, the EMV, and the Eye-Hans is very similar, and so is what Star are trying to do with the ICL, and Zeiss has the so many women's names, I can't remember. Asfina or something, I can't remember which one it is. The Vivity is not exactly EoF, it's EoF-like. The Art IOL is definitely spherical aberration, and the light adjustable lens can be made to change the spherical aberration, and actually the results for the light adjustable lens are incredible. Arturo Chayet did the first study. I want to point out an interesting scientific error made by Starr. So they decided to not go with diffractive optics. And of course, is it Rayner that already did an add-on that was diffractive, I think? I think so. Anyway, it was a bit of a flop because diffractive optics are a flop. Especially if you already have good optics. I mean, if you have a cataract and you put a multifocal in, you're just better, so you're good. But if you have good optics and you decrease the optics, not so good. So they went with spherical aberration, but what they forgot, and they got terrible results. This product is a flop. You look at the 20/20 rates, 20/20 rate, 32%, 20/20 at distance. That is way worse than the ICL without the spherical aberration in it. And they made a mistake. And I had nothing to do with it. I didn't talk to them. They didn't talk to me. But when you try and copy something without asking the people who know a lot about it, you may end up making mistakes. And what they've done is they've forgotten that the spherical aberration in these lenses is in the lens, and the lens is centered geometrically in the eye. But the visual axis is not necessarily geometrically in the center of the lens. And what happens, what aberration gets induced if you take a spherical aberration and move it to the side? Coma. So these eyes are suffering from a lot of coma, and which aberration does the brain filter very well? Spherical aberration. Just give me one aberration that the brain doesn't filter very well. Coma. Yeah, good. Okay. Well, you can all consult for Starr on the next round. But anyway, that's a total flop, and I don't know anyone who's putting these things in at the moment, and it's a shame. But because they could have got it right, because there are things that they could have done. Anyway, that is part one, finishing smack on time, which is pretty good for me. Thank you. So we can take a few questions, and I think we have a break, right, Tim? Yeah. Yes, microphone for the questions.
Yeah. Is it working?
Yeah.
Thanks so much for a really great talk.
Louder.
Hello? Can you hear me now?
Yep.
Okay, thanks so much for a really great talk. My question was just around the chart which you showed how much spherical aberration was induced in myopes, hyperopes, and emmetropes. It seems like the amount of spherical aberrations induced in emmetropes was very little. Was it sort of sufficient to still give that extended depth of field that you want to achieve?
Yeah, you're right. You're right. So why is it that we ended up with this equation? So the algorithm, which I mean, I have a financial interest in this, so and there's a reason for that, and that's because Tim and I developed this algorithm. There it is. Tim and I developed this algorithm ourselves, and Zeiss literally. I expected them to change it, and because they're optical scientists and I'm not. But they just programmed it directly into the software, straight from our Excel sheet into the software. Now, what we see, there's a trade-off when you're playing with the spherical aberration of an ablation profile. The higher the aberrations you put into the profile, the lower the accuracy of the sphere and cylinder correction. So we had to balance, and I did this literally like that. I mean, I just sit this. I remember, Tim, I sat there and I said, okay, up to -3, and then from -3 to -5, let's aim for that. Literally off the top of my head, having done 800 eyes, and we had this graph of how the spherical aberration changed. And so when you're dealing with an emmetrope who has plano -0.75 SIL, or like, let's say, +1/4 -0.75, that's an emmetrope. That patient, if they are not +1/4 -1/4, or plano -1/4, or plano, they'll be unhappy. So the accuracy in those patients is so critical that we don't want to lower our chances of hitting the refractive target by trying for too much depth of field. And so that was the principle. And when we put it into practice, we found that, oh, well, that seems to be enough then. Great. That doesn't mean that there aren't occasional eyes where I do put more, and there's a field in the software where you can manually input more spherical aberration control yourself. And I did that in my eyes. In fact, well, Glenn did it in my eyes, but in the video, I was just thinking we could probably, yeah, we can because it's a closed shop. Later on, when we do the surgeons having presbyon section, I'll show the little segment of that was on the BBC of Glenn doing my surgery. I put extra into my distance eye. I thought, you know what, I might not hit target and need an enhancement, but I probably will, and I don't care about enhancements because only 5% get ingrowth and it doesn't matter because it doesn't affect anything and growth can be managed. So I put in a lot of extra, and so actually maybe that could be a reason why I'm 20/10 and 40 seconds of stereo, because I gave that eye extra, yeah? I think that answers your question. Yeah.
Yes, great. So for patients who want maybe more intermediate vision and their imatropes, would you assume that maybe they won't have such of a sort of blended zone, maybe like you say, try and get them, maybe aim for like -1.3 instead of 1.5 or 1 to give them that more intermediate?
No. Well, yes and no. For the most part, if someone passes the +150 acceptance test, which we're going to talk about later, if they pass it, one size should suit all. This is not monovision. It is not like monovision where you have to go, well, let's do a contact lens trial of -2. Let's do a contact lens of -220. Which one did you prefer? Oh, I thought -225 was better. Okay, well, we'll order those lenses. It's not like that. That's not the pre-op exam. The pre-op exam is, yep, they passed. Okay, next, they're going to have plano -150. That's the test. All of this mumbo-jumbo is part of a few patients because they are non-tolerant, and so you will titrate. They're non-tolerant of the full blend, but that's only 5% of the people who walk through the room. 95%, you just pass the test, stand in line there. Didn't pass the test, titrate, 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 stand in that line there. Production line. Very easy, okay?
So I'm going to tell my father-in-law to wait till our VisiMax arrives and not do the multifocal IOLs. That's what you're saying.
Sorry?
So I should wait till not do the multifocal IOLs and my father-in-law until we get our VisiMax. That's what you're saying.
I don't know. How do you get on with your father-in-law?
I'm a little bit scared, but get along.
So I actually operated on my mother-in-law. She's German. You can interpret that any way you like.
Dan.
No, you have to use microphone.
Where do you get the previous existing spherical aberration value? Do you have a standardized pupil size for every patient?
Every time we talk about spherical aberration, it's in a 6 millimeter zone. Doesn't matter what the pupil size is of the patient, we are talking about in a 6 millimeter zone. That's the standard. You can't do it in another zone. The software isn't written that way, and the way we communicate with each other is not in that way. Okay, we don't have too much more time, but another question. Last question.
I want to ask that for non-tolerant patient, still we can do presbyon after some titration or something?
Almost always. Almost always someone can have treatment. It just requires tolerance. But that's what's coming later this afternoon, is understanding how to do that.
But we use a tolerant test to select the patient.
Yeah. There's a 1-hour lecture on that this afternoon. So I won't answer it now. But yes, the answer is yes. Almost everybody can have treatment. Quick break.